Hi, Dr. Sharma. Hi, Dr.
Hello.
Nimish. We are meeting here today to celebrate the World Asthma Day. You know that Gina has this time given the theme of making inhaled medication accessible for all. Now, I think that means that we have the responsibility to prescribe and make inhaled medication accessible to all patients with asthma. So, what is your take on? Do you still prescribe the oral medication for patients with asthma?
The mainstay of therapy in asthma always has to be inhaler therapy. Occasionally, some patients who have severe exacerbations might need a temporary use of oral therapy to tide over the crisis. But the mainstay still happens to be inhaler therapy.
The long-term therapy has to be only inhaled
Always.
therapy. So, but we still see some patients like whom we give optimal therapy or maximum therapy for control of asthma, which is the maintenance medication. But still, they don't get controlled. So we label them as refractory asthmas or difficult to treat asthmas. So, how do we deal with them? How do you deal with them, Dr. Nimish?
So I think one thing is always check compliance, adherence, and there are ways and means we do this in our OPDs to make sure that the patient is actually taking it. And before we obviously label them as severe or refractory asthma, because the treatment varies significantly. When we say severe or refractory asthma, you're looking into a reason why they've gone into severe refractory asthma. So common complications that arise in long-standing asthma would include bronchiectasis, would include something called as fungal sensitivity. So basically, we have fungal spores everywhere in our environment, and we normally breathe them in and out. But in chronic asthmatics, they may get allergic or sensitized to these spores and cause conditions such as SAFs, which is severe asthma fungal sensitization, and in a larger scale of the spectrum called ABPA or aspergillosis.
And ABP is allergy bronchopulmonary aspergillosis.
Correct.
I personally feel that before we label them as difficult to treat asthma or we check their compliance, I feel the responsibility of every pulmonary physician and every physician who treats patients with asthma or COPD and who prescribe inhaled medication is to teach them the right method of taking. I think we should take out some time when we are prescribing them and teach them the proper technique of taking, because even if they are taking but the technique is not right, then they will still not get the drug inside the lungs, and then they will not be they will not be controlled. I think teaching of the technique, making the drugs accessible to them, prescribing, and for the long-term maintenance therapy, inhaled therapy should be the mainstay of treatment, and that is, I think, the theme for this year's World Asthma Day. So now, once we have labeled the patients as difficult to treat asthma or severe asthma, refractory asthma, so then how do you treat the patients, Dr. Sharma?
See, when you have a patient who is difficult to treat, as Nimish mentioned, it is so important to make their sequence wise, as you mentioned rightly, whether the inhaler technique is the right way, if it's correct it if it is wrong, and look for other reasons why it is becoming difficult to treat. As he mentioned, fungal sensitization, you might have to do some allergy tests. You might also have to look at the home environment and see if there is enough control of common dust mite allergies. You might have, sofa sets which have got upholstery, which can be the source of, or a carpet in the house. So common environmental triggers should be identified. Besides that, maybe you would also have to do a lung function test, see how the lung functions are behaving, whether there is emotional stress can be a cause for difficult to treat. Gastric reflux disease could be a very important cause. So there are many things that would have to be looked into, and a good detailed examination and inquiry into the symptoms can sometimes give you a clue to as why the patient is. And then when you have identified a cause, then modification of the treatment, appropriate inhalers, maybe add oral medication if required, and that is the way one would go.
Now the biological therapy is also coming a big
So
way.
I think earlier the dogma used to be if you can't treat with inhalers and oral medication, steroids or a low dose maintenance steroids. But we are realizing now, as medicines have evolved, is that you should try and avoid getting the patient to the stage of needing inhalers or low dose inhalers. So if a patient is requiring more than 2 courses of steroids, oral steroids, in a year, that would itself should raise red flags to say that these newer biological agents are available and accessible now, and that one should consider these, because these really have been game changers. We've seen that not only does it reduce the rate of flare-ups of asthma, but also improves the quality of life in terms of breathlessness, cough, wheeze, and also the lung function. So you have objective and subjective measures which have significantly improved by the introduction of these medications.
So as we rightly said that these difficult to treat asthmas or refractory asthmas can lead to severe complications, like it can cause bronchiectasis, which is an advanced lung disease, and you can have some like ABPA can sometimes lead to cavitation. It can cause cylindrical central bronchiectasis. They can lead to cavitations, and at the end, it can. So we know that asthma is a reversible form of disease, but then in the long run, if it's not, particularly when it's not absolutely controlled or is refractory to our normal treatment, it can become irreversible also. And then whatever amount of biologicals you give or the inhaler therapy you give, that it has gone to an irreversible stage, and that means that it has reached a stage where it is beyond our normal medical treatment. So on this asthma day, I am taking an opportunity to launch Advanced Lung Disease Clinic here at our hospital, the Sir H.N. Reliance Hospital, where we'll be dealing with all types of advanced lung disease like bronchiectasis, advanced COPDs, interstitial lung diseases, which can ultimately progress to right heart failures, and the patients can be candidates for lung transplant. So that is so can you talk about some of the diseases which can lead to where this advanced lung disease center can be helpful?
So I think one of the commonest and actually most prevalent now, which an exponential rise in diseases, is interstitial lung disease. So interstitial lung disease is a broad term for a very large basket of conditions. And we are seeing that a lot of patients are being rightly picked up. Earlier, they would have been misdiagnosed as functional or severe asthma or COPD. But now with good CT imaging available and diagnostic modalities, we know that these are all interstitial or ILDs or lung fibrosis, as it's commonly known in layman's terms. And these diseases are something that we know that we can keep under control, but we can't arrest the progression. Which is why that at the appropriate time, once you know that the disease has gone beyond a certain limit, which we assess in our clinics, is to appropriately refer them on, if relevant, for lung transplantation.
Absolutely.
And that is our biggest cohort where we refer patients for transplantation.
And what about the COPD patients, Dr. Sharma?
Yeah,
Same.
Advanced COPD patients who are have a very poor quality of life because they have extremely reduced exercise capacity, or who are on oxygen for regular oxygen therapy, they are also candidates for referral to lung transplant. And I just wanted to mention the incidence of interstitial lung disease in our population is definitely higher. Even the younger population is suffering because of a lot of pigeon related exposure, bird exposure, which is what we call as a pigeon breeders disease. It's very, very prevalent in our city, and a lot of young patients are coming with lung fibrosis and advanced lung fibrosis, and some of them are on continuous oxygen therapy. They are the ones who would definitely have benefit with lung transplant.
And as we all know that all these advanced lung diseases will cause pulmonary artery hypertension, which ultimately will lead to right heart failure. And I think what I know of, what I have read, is that once a patient with a advanced lung disease develops a right heart failure, the median life is around 3 years. They don't survive more than 3 years. The same goes for patients who are having obstructive sleep apnea and then they go into CO2 retention, which is called like in patients with obese patients with obstructive sleep, severe obstructive sleep apnea, start retaining carbon dioxide, which we say as obesity hypoventilation syndrome. Again, in those patients, they will develop ultimately pulmonary artery hypertension with right heart failure. Now, these are again the candidates where a transplant is needed. In these cases, it will be a heart-lung transplant probably. So these, I think, we can summarize, Dr. Nimi, we can summarize the patients. I feel the asthma is a type of disease where, to begin with, it is not an irreversible disease, it's a reversible disease. But if it is not controlled, not well diagnosed, as Dr. Sharma said, we are not able to pick up the triggering factors or the controlling factors, then at some point in time, it can go on to make the remodel asthma and then progress like a COPD, or it can lead to, in case of ABPA, can lead to bronchiectasis and can become an irreversible lung disease, and then it can also mandate a transplant or treatment in an advanced lung clinic. So, Dr. Nimish, can you just sum up the diseases? First of all, Dr. Sharma, can you just sum up what we talked about asthma, and as per the theme of this year's World Asthma Day, that make inhaled treatment available for or accessible for all. Then Dr. Nimish, I would request Dr. Nimish to sum up on the advanced lung clinic and then the scope of diseases which will be covering in the advanced lung clinic.
So asthma is a very common condition in the population. The incidence is not rare, it is quite common, and it is quite nowadays we see an increase in the incidence of asthma because of the exposure to pollution in the city and the other reasons which are increasing the incidence of asthma. However, when early diagnosed and treated appropriately with good inhalers, this can be a potential cure. Well controlled, and patients do well, and they don't suffer consequences of poorly controlled asthma, as we mentioned earlier, that they progress to developing chronic lung issues, which tends to go more into a sort of a COPD-like pattern, or developing pulmonary hypertension. That can be definitely avoided. So it is very important to pick up early and treat early adequately with inhalers, and they do well.
Dr. Nimish, about that.
Yeah, so just to summarize our advanced lung care clinic, so here we are going to look into patients with multiple comorbidities, complications, with a multimodal approach. So we involve in other specialists. As you mentioned, when you get right heart failure, you may need a cardiologist on board. If you have an autoimmune condition associated with your lung fibrosis, we'll have a rheumatologist on board. So it's going to be a multimodal and a holistic view of the disease. And right from diagnosis to management to advanced care, where either the patient gets referred to rehabilitation, or if they do end up progressing for transplantation, that's the approach the clinic is going to take.
And the clinic will be encompassing all these facets, including the diagnosis, the routine management, referrals to cardiologists, rheumatologists, or any other specialties, then pulmonary rehabilitation, and at the end, if any of the patient groups are heart lung transplant or lung transplant, it will encompass all these modalities. So that will be the purpose, and I hope that the way we have been catering to our large base of patients with affection, with respect till now, we'll be able to do with this clinic also.
And to mention, our hospital has the facilities and we have advanced equipment.
Absolutely.
And we are able to provide that sort of a service to our patients.
Absolutely. So, thank you, Dr. Sharma. Thank you, Dr. Nimish.
Thank you
for this short. Let's gear up for the World Asthma Day and for our Advanced Lung Disease Center.